So let's move on to learn some more about how we can actually diagnose our patients with MIs, because that's the important part, right? Now, you're going to use this knowledge one day no matter what type of doctor you're going to be, because someone in the hospital or clinic is going to have an MI, unfortunately, and at some point you need to be ready to respond and diagnose this. The lab values are crucial in order to determine the difference between stable angina, unstable angina, and a true myocardial infarction. Remember, necrotic myocytes have lost their plasma membrane integrity, so they can leak out intracellular molecules such as troponin, T, and I. Again, troponin, T, and I. It takes at least 4 hours for that intracellular damage to get to the point where we can lose plasma membrane integrity and leak out contents. Where are these coming from? Look at this. Necrotic myocytes leak out intracellular molecules such as troponin T and troponin I. These are part of the sarcomere activation complex here in your image. Do not forget that we leak out everything. This also means cytosolic enzymes such as LDH and creatine kinase MB, also called creatine phosphokinase MB. These are also going to join the party. So listen up right now. Focus on, zoom in here. The most important markers you need to know are the proteins that are specific for the heart myocytes, which are troponin I and T. Even though they are found in other types of muscular tissue, the type of troponin I in cardiac tissue is transcribed from chromosome 1, while the troponin I in skeletal muscle is transcribed from chromosome 11. So clearly there has to be some difference, and there is, and that is why troponin I, made from chromosome 1, found in cardiomyocytes, is specific for a diagnosis of myocardial infarction at least 4 hours after the MI. Do you need to memorize these chromosomes? No, but it is a great way to demonstrate how they are two completely different troponins structurally. So after the onset of an MI, you first see these cardiac elements in the blood in about 2 to 4 hours. So why not immediately? Remember, it takes a second for hypoxia and ischemia to cause enough disruption of intracellular processes such as maintaining the mitochondrial and plasma membranes to allow leakage of intracytosolic enzymes. This is why we have a 2 to 4 hour delay. Let's visualize that here. How incredibly high yield this is, I can't even tell you. Look at this arrow. Troponin I, which is unique to cardiomyocytes, chromosome 1, as opposed to troponin I in normal myocytes of skeletal muscle, which is on chromosome 11, troponin I peaks right around 2 to 4 hours. After 2 to 4 hours, this marker enters the lymphatics, goes into the venous system, and bam, that is where we stick them with our needle and get that venous blood so we can sample and see if they have any troponin I present. It is highly sensitive and specific, meaning that you will not have many false negatives or false positives. If you have a clinical suspicion that someone suffered an MI and you want to stick them for a blood draw. Now what about CKMB? What does this even mean? Well, the MB part just tells us about the two components, M and B. All tissues need creatine phosphokinase, and the combination of M's and B's helps us figure out where it came from. For example, CKBB is a homodimer, that is why it is two B's together, that is found in the brain. Unfortunately for us, CKMB is not unique to cardiac myocytes. It is also in skeletal muscle. So checking for CKMB is highly nonspecific. That is, that you can also have a false positive just from someone working out really hard and saying they had chest pain. They may have not suffered an MI, but they may have strained a muscle, and the combination of they already have some underlying atherosclerotic disease, they may have suffered a little bit of angina, and you check their blood and you see an elevated CKMB, but in fact it is just from a damaged peripheral skeletal muscle. So that's a situation that we need to be careful about. So why do we check for CKMB? Why is it helpful? Well, let's look a little bit more into it. CKMB also begins to rise within 2 to 4 hours because it was liberated from those myocytes just like troponin I at the same time. But it peaks at 24 hours or 1 day. And it has a pretty serious drop around 48 to 72 hours. As you can see here, it drops down significantly. as opposed to troponin I, which is continuing to trend around a little. It decreases and then plateaus off, as opposed to CKMB, which kind of tanks around 48 to 72 hours. This means that in the early onset of someone having chest pain that's in your emergency department, you are going to have to check for both. And if they really suffered an MI, both of these markers will be elevated. So again, why is CKMB even drawn? Well, it allows you to confirm that someone had an MI if their troponin I is also high. But if you see it peak again, so if it's trending down low and then boom, comes right back up after 48 to 72 hours, you need to be really curious if they suffered another myocardial infarction. Again, CKMB does not tell you for sure that they actually suffered another one, but if you know that they had a myocardial infarction earlier and they return with signs and symptoms of another MI, the correct answer is to check for CKMB to see if they potentially suffered a reinfarction. Why can we not check troponin I, which is the dotted red line? Look at the graph. This cardiac marker stays elevated for 10 days. That is not helpful at all. If we check the blood here or here, the value is going to be the exact same, right? It'll still be elevated. Unless we catch it at the exact peak where it increases, it's still going to be very confusing to help us delineate if there was another myocardial infarction within a 48 to 72 hour window after suffering the initial event. So, what else do we need to know about the diagnosis of a myocardial infarction? In the first 6 hours of someone presenting to your emergency department with chest pain, you need to take a blood sample, looking for these markers. You need to do an electrocardiogram. And if it's within 90 minutes of the onset of the signs and symptoms, they go straight for cardiac catheterization. If you see any abnormalities such as ST elevation or ST depression, indicating a transmural or subendocardial infarct, is when they go to the cath lab if they present within 90 minutes. Now, Q waves are a very interesting ECG finding because they indicate an old or advanced transmural infarct. This may seem rather confusing because we know that our normal depolarization includes a P wave, a Q wave, an R, an S, and a T repolarization wave. So how does a Q wave tell us that we had an old or recently advanced transmural infarct? Well, a pathologic Q wave indicates that this Q is super deep. Instead of this tiny little cleft here, it goes way down, and that is pathologic. Let's visualize this with the sequence of depolarization in the ventricles. So I'm going to draw out 4 ventricles to show the sequence of depolarization activity. Excellent. So this is our left ventricle, this is our right ventricle. The pathophysiology behind a pathologic Q wave is that there is a segment of myocardium of the left ventricle that does not contract because it does not conduct electricity. Let's say we blew out this segment here, and there's only a little bit of viable myocardium left in it. So in all of these images, we need to blow out these myocytes. There's only a tiny bit of conductive capacity left in these cells because they mostly are necrotic from a transmural event. Either they are currently suffering a transmural infarct or they previously did and it was replaced with fibrosis. So, for example, we infarcted this entire left lateral wall of our ventricle because we infarcted our marginal branches or left circumflex, the marginal branches coming off of the left anterior descending. Do not forget, the left circumflex also supplies the lateral wall of the left ventricle. It's a dual blood supply because it's such important real estate. You have to know these things. So let's look at lead 1. We know that lead 1, if this is the chest wall, it's part of Einthoven's triangle, and it travels in this direction with the positive electrode, which is the sensing electrode sitting at that vertex, right? With 2 and 3 going towards the feet, right? So let's look at lead 1 and imagine the depolarization sequence as it happens. So how do we have these pathologic deep Q waves? Remember, the positive electrode is the reading electrode. It's over here on the left side of our patient's heart. So first thing to depolarize is the interventricular septum. This travels from left to right. This is our first depolarization wave. That is initially read in lead 1 as a negative deflection because the depolarization wave is going away from the positive electrode. So we already have, this is our baseline, this is our negative deflection, right? When you depolarize away from the recording electrode, it is a negative inscription or writing on our ECG paper. Now what about the next step? Well, the next step is that this initial depolarizing event here spreads in this manner, where we get a depolarization of the interventricular septum, creating a net depolarization in that direction. And this continues to inscribe a slight negative deflection because it's still away from the positive electrode, but not at such an angle that made such a negative deflection in our initial diagram. So the theme here is that the interventricular septum depolarizes in this area. It will spread throughout the rest of the interventricular septum, and we know that it will depolarize the right and the left at the same time. But since the larger mass of the left ventricle takes over and creates the net electrical vector, we normally have this swinging from right to left with the net vector in this direction. Now, this is where the pathologic Q wave comes in. We are supposed to have simultaneous depolarization of the right and left ventricles with the net electrical vector towards the left ventricle. And that is what we drew here. This is the positive electrode, and that's why we get a large R wave. But the situation is that we infarcted this left side. Remember, this tissue's all gone. Usually there's more myocyte mass on the left, but we infarcted that wall. So there is no significant amount of current conducting through that tissue. The right ventricle is fine though, and it's going to be the only place depolarizing. So now we have this abnormal. Instead of this net vector, the right ventricle will create the net depolarization vector. And as you can see, just like this arrow, it is away from the recording positive electrode. Now what does that do? It inscribes a very large negative deflection, which is our pathologic Q wave right here. It makes the Q wave really deep because the healthy muscle on the right side of the heart is creating a net electrical vector that is not matched by the infarcted left side. Remember, normally the non-infarcted left side would create a net electrical vector in this element or this direction, but since that mass and those myocytes are gone, the only viable tissue is the one that's going to be depolarizing. Eventually, though, there is some contraction of whatever remaining viable myocardium is left in the left ventricle. Because if we infarct the entire left ventricle, we're dead, right? So there's still some viable myocardium. And eventually, remember, because there are gap junctions in between myocytes, this depolarization will travel from cell to cell, all the way over, and it'll trigger that left ventricle to depolarize. We do eventually get the rest of our complex. So we get our peak because we eventually do get some left ventricular depolarization. The main thing I need you to remember is that pathologic Q waves are a sign of transmural infarct that is either recently happening or resolved, and there's a hypocontractile left ventricle which causes the right ventricle to depolarize and create this very deep Q wave. And it is pathologic because it indicates that there was some left ventricular wall abnormality that it did not depolarize in synchrony and take over to create that net electrical vector that we like to see in a normal ECG. Now, another flash quiz. What syndrome is associated with coarctation of the aorta? I think we know this one. Turner syndrome. Remember, Turner syndrome is due to having a single X chromosome, only in a female. There are a lot of lymphatic abnormalities and vessel abnormalities in general that present with a webbed neck due to accumulation of fluid in the interstitial space. It creates a very webbed-like appearance, just like imagine the gaps in between a duck's foot. This is due to accumulation of lymphatic fluid in the subdermal tissue. As you would expect from only having one X chromosome, these females have trouble with primary amenorrhea because oocytes need 2 active X chromosomes. You need that? See that? This is where they can tie in a reproductive question. You need 2 active X chromosomes for oocyte development. In addition, the deficiency of estrogen relates to some of the bone abnormalities seen in Turner's patients. Remember, they have streak ovaries, right? They're not producing estrogen at a great enough amount. Some of the bone abnormalities seen in Turner's patients include a wide shield chest and a wide carrying angle. The shield chest results in widely spaced nipples. They can be hypoplastic due to lack of stimulation by estrogen. We know that estrogen is a protective hormone against bone degradation because it regulates osteoclast apoptosis. Now, what is this wide carrying angle? A wide carrying angle refers to the angle made from the humerus, which is this bone, to the forearm. The more abducted AB the forearm is in relation to the humerus, the wider your carrying angle. So, this is the angle that we're discussing. Remember, abduct means away from the body. Adduct is to add to the body. So abducting means to go away from the body, and adducting means to add to the body. So a wide carrying angle means that this angle is much greater because the forearm is adducted much greater than you would anticipate.